Okay, you guys all overall did really well on that quiz, so good job. Um, there's some stuff that I want to review before we jump into the content for week 8. So, you guys have your discussion post number 4 due this week. So, just a little reminder, your initial post should be submitted by tonight, and then you're following up on 2 of your peers' posts by Sunday. Okay. A couple of you last time only responded to one of your peers. So just to make sure you guys are getting full credit for your homework, make sure you're responding to 2 of your peers and that you at least have 2 different days of submission, that you're not submitting all of your stuff all at the same time. Okay. You also have your normal newborn sim chart that's due this week. Last week there was a mess with the assignment due date. So that is why some of you guys had zeros in for that assignment. I went in and manually changed all of the ones that had been submitted. So you guys should have your grades in there now and they should be accurate. If it still says 0 in your column for that, the ECV sim chart, will you just reach out to me and let me know that you submitted it so I can go into SimChart and pull it over? It's not automatically going to just populate your grade like it usually does because the due date got kind of messed up for that. So if you have a 0, but you submitted that assignment, definitely let me know so that I can go in and change it for you. Okay.
All right, I'm gonna go do this fucking class. Give me a break.
Lorena, can you mute your
Oh,
and turn your camera on, please? Tamika, I need your camera to be on as well. Okay, I think Tamika is working on getting her camera on. So you also have your Saunders and Clux questions due this week. So remember that you need to have your name and your heading on top of that submission whenever you're sending it in to me. Otherwise, I'll have to have you resubmit it and it will be counted as late. Okay. Next week is exam 3. If you guys are kind of borderline with your grades going into exam 3, I would really recommend meeting with me before that exam so that we can kind of go over ways to help study, things that I want you specifically to review, what you guys are and are not doing as far as like preparing for the exams. The schedule for the exam 3 review schedules have been posted to all of the sections, so you guys have access to that. And I would definitely recommend you going to at least 1, if not 2 of those review sessions. That's going to be very beneficial for you going into this final exam. Okay. Um, Again, don't wait until after the exam to ask to meet with me about your grade because all we'll have left after that is your HESI exam. So it's better to meet with me before going into the exam rather than after. Okay. Does anyone have questions about the homework that's due? Um, Going into next week, you also have your HESI RN maternity assignment, which I was going to see if Professor McBride would help explain briefly. Um, before we go into that week so that you guys kind of have an idea of what we are expecting.
Oh, okay. So the HESI maternity practice exam and the HESI maternity assignment exam. They say exam, they are not KGA. All right. It's just homework. It's long. Take your time. Okay. There's no time limit, so you can use your book or whatever. It's gonna grade your first attempt. And it's like 100 questions. All right. So that's why I say take your time and and use your book or whatever you need. Okay. They both are similar names, and you should not have a problem when you link to them from your module. You shouldn't have any problems with getting into the right assignment, but make sure that you're doing the assignment exam on the week that you're doing that, and then the practice exam is the following week. So make sure you're doing the right one. And then the grade comes over to the grade book automatically, kind of like your sim charts. Okay. That's pretty much it.
Can you
Great.
say it one more time? Which one are we looking at? Because I'm over here. Is it
Sign
the practice? Hey, see, that's what we're talking about, correct?
the practice exam and the assignment exam. Hold on, let me pull up the module so I can look at it so I don't say it wrong. So we're in week 8 right now. And so in week 9, hold on, so in the modules, so right now we're in week 8, right? So Professor Young just told you we're doing our discussion. We're doing the normal newborn sim chart this week. We're doing the Saunders questions, and make sure you look and see what it wants you to do. Oops, I don't want to link to it. Okay, so you're gonna do health problems this time, and then do maternity and newborn. Okay, and then the ones we were talking about are the maternity ones. So when it says HESI RN maternity assignment exam, that's the one you're going to do in week 9. Okay, and that's the one we're talking about. But there's another one that happens in week 10 that's very similar, and it's the HESI RN maternity practice exam. So make sure you do the assignment exam in week 9. Practice exam happens in week 10. And if you're linking to it from your module, it should take you straight to it, no problem. Okay.
Is there any way we can get the access that other classes have with the exam 3 stuff? I noticed that other classes have access to the videos that are being posted, but we don't have access to all of it.
I think you have everything the same because I sent it all to every shell.
No, there's a couple of announcements that others have gotten that are in different, like Dr. Roberts' class, that we do not get. It was one that was like labeled the live recordings or something of that sort, and it had Dr. Roberts' exam review and all that other stuff, but we don't have that. We have one, but it looks like there was only 2 that was actually posted.
Well, everybody puts them in their shells differently, but there weren't any students that came to this one. There weren't any students that came to this one. This one was canceled, and I sent out my link for my review this morning. So Dr. Roberts, I know instead of putting them in her announcement, she will send out another announcement that says, here's the review session for this person, or here's the review session for that person. But there shouldn't be anything that's going out that's different. Because that's kind of the point, is that every students get everything the same.
Professor
Oh,
McBride, where
there
is
were.
yours at? Because I haven't seen yours.
No, yeah, I'm telling we don't have access to any of that.
That is actually your announcement that I have open right now.
Okay, so for exam
I
2,
came to Professor Young's review Monday.
Oh yes. So, but I said it. So I said no one came. I apologize. Only you came. I think the 2 of you had kind of a one-on-one. So
Yes.
recording available. So I
Yes.
should say it differently. This right here that I have open. I am in your announcements right now.
yes, ma'am. I can send you what I'm talking about if I can get that person to send it to me, because we just don't, like for exam 2. Of course, I'm not really talking about exam 3. I need I need that information for exam 3, but for exam 2, we don't have, like, I wanted to listen to Dr. Roberts was never posted for us, and then I think it was like Shoemakers was never, or Shoemake was
Yeah.
never posted. I was just seeing if we could have access to all of that.
Okay. Well,
And have access to it for exam 2.
you want the exam 2 ones now?
No, I just want what everyone else sees for exam 3.
The only review session that's happened that will actually have a video is Professor McBride's from this morning, which I'm going to post at the end of the today.
Okay.
I think that they're saying that they didn't get all of the recordings for exam 2.
Or exam 1. So what my thing is I just would love it for exam 3, because there's a lot of them that just coincide with the sim that we do, the clinicals that we have, and then classes. So we all can't always make those, but I would love to still listen to the recordings. But like I said, we just haven't had that.
Okay. So I can also look and see what's in your announcements from exam 1 and 2, but that part doesn't matter at this point, right? So Professor Young will make sure she's posting them. Professor Young, do you put it in that announcement or do you send it out separately?
I put it in that announcement and then I push a send so that you all get a notification that it's been updated.
So keep looking for that announcement. Go back into that because that's how I do it in my class too. So keep going back to that exam 3 announcement and keep looking because the recordings are going to be added into there. And every time you get a new announcement that says, or a new notification that says you have an announcement regarding exam 3, don't disregard it because that means there's been stuff added. Okay, and then she'll make sure that all the recordings are in there that we have. Because it was like so far, the only recording that's available so far for exam 3 is mine from today. And that'll go out, she said, tonight. Okay, but you want to make sure you have Dr. Roberts and Dr. or Professor Shoemakes.
Yes.
Okay.
From exam 2 or for the one they're going to be doing?
Just the one that they're going to be doing. I've had it sent to me just by other people for the exam 2, but I just realized that we never had access to it. So I just rather get it from you guys than to have to bother another student.
Well, and that might have been an oversight, and so we apologize. Okay, but right now this for exam 3, the only recording that's available right now is mine, and that'll be posted. Professor Shoemake is having her review on Saturday, and Dr. Zeller's having her review on Sunday, and Dr. Roberts is having her review on Sunday. So these also may not overlap with other sim and clinical things you have because they're on the weekend, and maybe you can actually attend those, which is definitely better to attend than to watch the recording if you're able to. But we will make sure that all of your stuff's posted. Sorry, Professor Young, I took up a lot of your class time.
No, it's okay. That was good. Does anyone else have any questions about review, schedule, homework? Okay, so last week we were not able to get through the entire PowerPoint. Were you all able to access that on your own and review that on your own time? We'll try at the end of this day of today, if I get through the PowerPoint that we have for week 8, to go over some of the main key points from week 7. I can't guarantee that we'll have enough time to be going through the entire PowerPoint. So it is important that you take some time on your own to go over that stuff so you're not missing any of that information. Okay. The other thing too, that's important about before going into exam 3 is this content with newborn is a lot. There's a lot of content with the newborn stuff. So making sure that you guys are studying in the way that pertains to you. So I know we give you guys a lot of resources and a lot of information, okay? And I've met with a couple students this week, and it's really good that we have access to all the resources and information that we have, especially because every professor teaches different, every class is formatted a little bit differently. Sometimes I know some students have been having an issue narrowing down exactly what to study because this material is so dense and there's a lot of stuff that we go over. So if I'm like lecturing and I'm telling you, highlight something, or this is really important, or I really want you guys to know that, those are things that I want you to definitely like star, circle, make sure you're taking that into consideration. When I was reviewing our exam from exam 2, you guys were doing really well on select all that apply questions and critical thinking and application questions. The things that I saw a lot of people missing were if you have a mom who's presenting with something pathophysiology wise, so like a hemorrhage, okay, knowing, okay, this is what's happening in her body. What is the priority action because of how this mom is presenting? I know this is a little confusing because in med surg, you guys are taking that class right now, right? Alongside this. So in med surg, every answer is airway, is what they're telling you, right? Airway is number one. Airway is the most important. In OB, that is not always the case. If your mom is hemorrhaging, what is our priority intervention?
Stop the bleeding.
Exactly. So we, as OB nurses, when taking these exams, instead of focusing on like the whole entire big picture of that patient, exactly like what they're telling you to do in med surg, we need to be thinking, what is happening in this specific patient's body and what is our priority intervention because of that? Okay. That was something I thought overall I wanted to review just briefly with you guys because you guys are doing really well with application and critical thinking questions and select all that apply. It's just kind of taking these different things that are pertinent to OB and realizing that that your answer might not necessarily be like airway. There's other things that are prioritized whenever you're talking about OB emergencies, right? So take that into consideration when going into exam 3. And then a lot of things too that I talked about with other students was just taking the time to read the question all the way from the start to finish, because there's a good important information that you guys need to have in the entire time, the entire question. Okay. So does anyone else have any thoughts or questions about any of that? Okay. I wanted to give you guys a choice because I know it's the night before Thanksgiving and you guys are going to be pretty checked out. There's a lot of information. So we can skip our break today and end early. It's not going to be crazy early, right? It's like 15 minutes early. Or we take our break like normal and end at normal time. So show of hands, who wants to end class early? Okay, we will do that. Also note, I am currently 16 weeks pregnant, so I might need to take a 5-minute break to go to the bathroom. Okay. I'm just letting you all know. But yes, first baby.
Congratulations.
Thank you. First baby. It's a girl. We're really excited. Thank you, thank you.
It's a girl.
It's a girl.
Oh my goodness.
Yeah, we're really excited. So she's due in May of next year. So, but if I have to get up and pee a couple times, I'm sorry. But let's go ahead and jump into our PowerPoint because this is a lot of material to cover, and high risk newborn is really, I really want you guys to know this information. So, okay, let's share this and get started. Alrighty, so before we get into like the really high risk stuff, we need to discuss nutritional needs of the infant and like feeding and how as nurses we can help moms with nursing and what our role is in the entire process. Okay, it's really important for babies to get good nutrition in the first well, pretty much forever. But, the first 2 weeks is the really important part because babies are pretty sleepy. They're not going to want to nurse on their own. We're going to need to help mom. We're going to have to help baby a lot whenever it comes to feeding. So, nutritional needs of the infant aren't really that different from nutritional needs of the adult. It's just a little bit different because their primary source of nutrition is formula or breast milk, right? So, you can see here that during the first 2 days of life, they're going to need 80 milliliters per kilogram of fluids per day. They're losing their fluid through urination and respiration effort. So we need to really pay attention to their intake and output. This ties into our assessment from last week, where we're assessing their renal function, we're assessing their urine output. Babies should have their first pee within 12 hours. They should ideally have their first poop within 24. Okay. If babies are not urinating or they're not having adequate amounts of output, then we need to analyze how their input is going, how their intake is going. So if they're not feeding super well or they're having trouble with nursing, that's going to ultimately affect their output too, right? So we need to be monitoring them when they're in the hospital. Their energy levels or their energy needs are going to vary per age, weight, maturity level, and then like their growth rate. The fat portion of human milk is going to provide the greatest source of energy for these babies. Okay. Carbohydrates. So lactulose is the primary carb found in human breast milk. This is the most abundant carb found in the newborn diet up until they're about 6 months of age. Lactose provides calories in an easily available form. So this is important because it's slow breakdown and absorption, and it's also going to help increase calcium absorption. So most of the time when we're talking about carb intake, lactulose is the biggest one that's found in the human breast milk. The other really important one is oligosaccharides. And these, I just want to briefly mention this because these are going to be critical in developing the microflora in the intestinal tract of the newborn. Okay. So the probiotics, basically what they do is they promote an acidic environment in the intestines, which prevent the growth of gram-negative and bacteria. Okay. So breast milk, basically what I want you to take away from that, rather than all those big fancy medical words, is breast milk is really important for babies' immunity, and it's going to increase their resistance to GI illness. Okay. That's one of the reasons why we stress breast milk. This PowerPoint is not going to be like breast milk's great, formula's evil. Like, no, that's not how we are going to approach infant nutrition. Okay. We just want babies to make sure that they're getting their nutrition and that they're getting adequate sources of it. And it's just important to know what parts of it are the most important for the baby. So for fat content, human milk is comprised of lipids, triglycerides, and cholesterol. Cholesterol is essential for brain growth and development. Okay. If they're not feeding breast milk, we need to make sure that there is fat content in their alternative feeding method. So like when I work with the Amish population, a lot of them will feed their babies goat milk. Okay. That is not something that is uncommon with that patient population. It's becoming more increasingly common too with women who choose not to breastfeed, who don't want to formula feed or use soy-based formulas. So we really need to just educate moms on, if you choose an alternative source of feed, like make sure that there are these key components because these are important for baby's development. Okay. Protein. So human milk contains two proteins. They're called casein and whey. The primary whey protein in human milk is lactalbumin. So this is high in essential amino acids needed for growth, right? Protein high in amino acids, we need this for growth. It also has iron binding capabilities, and also it helps prevent bacteria buildup and helps with babies' immune systems, okay? Casein in human milk enhances the absorption of iron, which prevents iron-dependent bacteria from proliferating in the GI tract, okay? So whenever we're thinking of protein in these two things, we also want to know the importance of how it binds our iron for these babies and helps prevent bacteria growth. Okay. Human milk contains all vitamins except vitamin D. So vitamin D, what they recommend for moms is moms should increase their vitamin D while they're intake while they're breastfeeding. This could look like them just continuing their prenatal vitamin, right? Because that's included in the prenatal. So we usually recommend to moms to just stay with the prenatal throughout breastfeeding, just to help with their overall vitamin intake and also for babies. And then vitamin K is a really important one. That was important with last week too, which is why we give babies vitamin K shots, right? Vitamin K is important for blood coagulation so that babies aren't having any bleeds. It's produced by the intestinal bacteria, and like we talked about, it doesn't actually be produced by the newborn for about 2 weeks after delivery. Okay, so that is why we need to give them that vitamin K injection. If moms refuse vitamin K, which is something that we've seen a lot, we need to encourage moms to increase their own daily intake of vitamin K, or just be gentle when handling baby, right? Let them know about the risks that are associated if these babies do not have the vitamin K shot, that they are at an increased risk for bleeding if they were to get like bumped or something like that. And then minerals here, iron levels are low in all forms of milk, so it's important they're getting that protein to help bind the iron. Breast milk is better than formula or cow's milk in iron content. And then their stores of iron will deplete at about 4 months. So that's when babies are a little bit more at risk for iron deficiency. Okay. Before we continue, Emily, if you wouldn't mind coming back on screen. I can't see you. I think I see the top of your head. Thank you. Sorry. Okay. So we'll talk here about breastfeeding. The rates of breastfeeding have slowly increased. In the past, breastfeeding was not the most popular option, right? It also is going to vary based on patient population, cultural, and socioeconomic factors, which we'll go over those. We will go over those more in detail. There are lots of benefits to breastfeeding for both the infant and the mom. On page 583, table 24.1, you guys can read through all the different benefits. The biggest one is that it's said to reduce infant mortality, okay? It also reduces the risk for GI infections, Crohn's, ulcerative colitis, obesity in childhood, and the development of type 2 diabetes. We consider breastfeeding to be the gold standard for infant nutrition. It's really cool because breast milk will change what is in it based on baby's age and what the nutritional demands are of the infant. Okay, so that is, I think, pretty unique about breast milk, is that we're producing exactly what the baby needs at the age and time that the baby will need it. It's more easily digestible by the newborn, and it's really important in regulating their inflammatory response. Big things for mom as far as benefits. That reduces the risk for ovarian cancer, type 2 diabetes, hypertension, MIs, and it also is just going to promote bonding between mother and infant, right? Breastfeeding is a different kind of bond that moms and babies are going to have together because that is something that is unique to the mother, right? So it's going to help with bonding and formulating that bond between mom and baby. So whenever we're talking to our patients when they come in about making the decision to breastfeed, okay, we need to take into account what the patient's background is, what their support system is like at home, what their socioeconomic status is. Are they expected to go back to work in 3 or 4 weeks after delivering their baby? Are they in nursing school and just had their baby and have to go to classes and attend clinicals? You know, these are real things that people encounter. So we need to be talking to the moms about breastfeeding and formula feeding and what is going to make the most sense for that patient. Okay. We're not going to disregard all of the nutritional benefits for the baby, but we also need to have an open mind and be willing to admit that not every mom is going to be able or wanting to breastfeed because of certain situations that they're facing independently, right? There are some contraindications for breastfeeding, which I think you guys should definitely know those. If there's underlying maternal or fetal medical conditions, right? If a baby is being resuscitated, we are not going to try and latch that baby. We are going to try and make sure the baby is stable before we're worrying about feeds. Okay. If mom is not stable, Like she had a traumatic birth. She ended up bleeding a lot. She's not fully aware or with it. We are not going to be prioritizing breastfeeding at that time. While nutrition and feeding baby is important, there are other ways that baby can have nutritional intake that do not involve breastfeeding if mom is in a critical condition. Okay. Say mom has to stay in the ICU. That isn't going to be appropriate at that time. So another big contraindication to breastfeeding is if a mom has an active HIV infection, especially if their viral load is elevated at the time of delivery. Okay, because that infection can pass over that barrier and put the infant at risk. So moms that are HIV positive, we need to be aware and educate them on the fact that they may not be candidates for breastfeeding. Okay, breastfeeding with LGBTQ plus families. So an option that I've seen in the hospital for surrogate deliveries before has been donor breast milk. This is a really awesome option for moms that are not trying to formula feed and the baby needs supplemented, or also for partners like same-sex partners or any other type of family unit who they may not be able to breastfeed at that time. So moms that had a baby via surrogate, they're not going to be producing milk. So donor breast milk is a really awesome alternative. Okay. So we want to make sure as their nurse that we are giving them these options whenever they're in the hospital. So on this slide, I just have a picture of the benefits for both baby and mom. You guys can review that. Another picture here of benefits associated with moms who breastfeed. The biggest thing is the reduced risk of ovarian and breast cancer. That's a big one. Right? So anatomy of the breast, kind of going back to our anatomy days. It has 15 to 20 lobes, and then within each lobe is tissue consisting of alveoli. There's multiple pores that transfer milk to the suckling infant. Milk ducts transport milk from the alveoli to the nipple. The size and shape of the breast does not impact the ability to produce milk. Okay. Just because a woman may have bigger breasts does not mean that she's going to immediately have more breast milk. Just because somebody has smaller breast tissue does not mean they're not going to produce milk at all. It really has no impact on it whatsoever. Okay. Breast size naturally will increase. Veins are going to become more prominent. Nipples will become more erect. The areolas will darken and enlarge. The alveoli begin producing colostrum around 16 weeks of pregnancy. So you may have like patients who bring colostrum into the hospital that they were able to be hand expressing or getting out early on in their pregnancy, which is kind of awesome because if they have to supplement the baby, we can use that, right? So we don't need to use formula. Let's see, what else do I want to mention there? I think that is mainly it. One thing we also need to educate our patients on is if we're helping them with hand expression, which we'll talk about a little bit later in this PowerPoint, whenever they go to hand express, they need to start higher on the breast tissue and come down more rather than starting closer to the areola because they're going to need to get the milk from all the way back here, not up close at the nipple. That's something that we've seen moms do before where they'll just like be trying to squeeze like just the tip of their breast to get the colostrum out and they end up just making themselves really sore. So knowing the anatomy of the breast tissue is really beneficial whenever we're educating patients on how to hand express and how to use that method when expressing forward colostrum and milk. So the process of lactogenesis is how moms are producing their milk, how that happens, what the important hormones are doing in the body and what they're responsible for. So after delivery, there's going to be that giant fall in progesterone, which is going to trigger the release of prolactin from the anterior and pituitary glands. So what is our main function of prolactin? Did you guys read about this when you were studying this week? First, let's start with this. What are the two biggest hormones whenever it comes to lactogenesis? We just mentioned prolactin. What's the other one?
Oxytocin.
Yep, you got it. Oxytocin. which I know some people can find confusing because we have oxytocin in about 3 different areas of L&D. We use it all the time. It's in a lot of different things, right? So knowing when to use oxytocin and what it's being used for and what is its relevance is important whenever we're thinking about what's going on with mom and baby. Prolactin. So during pregnancy, prolactin prepares the breast to secrete milk, and during lactation to synthesize and secrete milk. So they're highest during the first 10 days after birth, and then the prolactin will decline over time, but remains above baseline levels for the duration of lactation. So your prolactin is basically helping produce milk, is what its main function is for. Prolactin is produced in response to infant suckling and whenever the breasts are fully emptied. Okay, this is a supple meets demand system where so moms are going to producing the amount of breast milk that baby is going to be demanding. So if your baby is latched on for like 30 minutes on each side, that mom is fully emptying her milk, which is going to stimulate the prolactin to produce more milk. If your milk is not being fully emptied from the breast, there's going to be a decline in production. So if moms are saying like, my milk won't come in, whatever, baby isn't getting enough, baby's not gaining weight, whatever is happening, we need to educate them like your baby should be nursing for at least 20 minutes on each side to fully empty that breast tissue so that the alveoli are being stimulated and the prolactin is producing more milk, right? So that is what our prolactin is doing. Oxytocin is essential for this process as well, because it is what is in charge of the milk ejection reflex, that letdown reflex. So as the nipple is stimulated by the suckling infant, the posterior pituitary gland is going to be prompted by the hypothalamus to produce oxytocin. And so, like I said, this is going to be responsible for the milk ejection reflex, that letdown reflex. It's basically going to be like stimulating that breast tissue to contract and send the milk forward through the ducts to the nipple. Okay, so your prolactin is producing the milk, the oxytocin is pulling that milk to the front of the breast for the baby. Right? This milk ejection reflex is triggered by a lot of different things. And you guys will have probably seen or heard of this or experienced it yourself. So thoughts, sights, sounds, or odors, specific things can trigger moms and can trigger this milk ejection reflex and cause them to like start leaking. It can be triggered with sex. It can be inhibited by fear, stress, or alcohol. So if moms are having trouble with their like milk production, we need to ask them like, what is your home life like? Are you working right now? Are you having a lot of stress? Is taking care of new baby putting a lot of pressure on you? Like, how are you feeling type of thing? Because their stress response will slow down the process of lactogenesis and decrease their milk response, their milk production. Oxytocin is also going to stimulate our uterine contraction, right? Because we're giving oxytocin after delivery to help contract that uterus, clamp that uterus down, and prevent any excess bleeding in the postpartum period. So moms may complain of having more cramps with breastfeeding. Okay, that's something that you guys should also know before your exam or for your exam. If they're experiencing more cramps with breastfeeding, that is normal because of the oxytocin that is being produced in the body with breastfeeding. This nipple erection reflex is basically just how the nipples are going to be everted or erect whenever babies are going to be suckling or whenever this milk is being produced and infants are beginning to feed. Does anyone have questions about lactogenesis or prolactin or oxytocin? Because that's a pretty big concept that I want you guys to know about. Okay. So this is a little diagram here showing like prolactin and oxytocin, some engorgement, insufficient milk supply, what that can mean. One thing that hospitals may do, which I'm not sure if you guys have seen this in your clinical setting, is the 10 steps to successful breastfeeding. That's been kind of adopted by a lot of L&D units. And it is just ways that nurses and things that nurses can do and help moms with to successfully breastfeed their babies, right? Because breastfeeding is challenging. If you guys have ever done it, like I'm sure some of you can relate to that. Whenever I've helped other moms do it, it can be really hard because, babies are moving and they have a mind of their own and they want to do what they want to do, and it can be kind of hard. Okay. Hold on one second here. Alrighty. So one of the first things that is something that is difficult with breastfeeding is just getting it started, right? Breastfeeding, the initial breastfeeding is really important, and it's not something that we want to overlook or ignore, but we also need to make sure that as nurses that we're doing our best to try and help with this process. So we want to watch and look for babies to see if they have any cues, if they're displaying that they're ready to start breastfeeding. So this would be that suckling and mouth motions. It would kind of fall in line with the the sorry, I just blanked. The reflexes, the newborn reflexes that we talked about when we were talking about infant assessment. So their suckling motion, their hand to mouth movements, the rooting reflex, that's basically going to give you an idea of whether or not baby is ready to start feeding. Okay. We want to try and get babies to latch within the first hour of life, ideally. We don't have to, it's not gonna like hurt anything, but as we know, babies have a hard time regulating their own blood sugar, right? So we do not want them too much time to pass after birth before we're starting breastfeeding. So initiating breastfeeding ideally within the first hour of life. With positioning, we want to take into account how mom wants to nurse. Okay. If it's a first time mom, we are going to be helping them a little bit more with that and showing them how to be feeding and how to position. But if it's a mom that's had four kids or whatever, and she knows what works best for her, then we need to respect that and we need to let her dictate where she wants to be. The four traditional positions are football, cross cradle, cradle, and side lying, which we have a couple pictures of them here in later slides that we can look at. And then we want to make mom comfortable, right? So the important thing with breastfeeding is observing baby's latch. That is what we call whenever baby successfully grabs hold of the nipple of mom's breast and is successfully nursing. Okay, we want to observe for a good latch. So we want mom first to kind of hand express some of her colostrum to the front of her nipple because babies will be able to smell that. They'll be able to taste that on their mouth and on their tongue, and that will initiate them to try and open their mouth wider and secure a better latch to start nursing. It is really important for us to look at a good latch because moms can get really, really sore if we are letting baby latch incorrectly. So this means that we're ensuring there's a full seal, that baby's not making any noises whenever they're nursing. If they're making noise, that means there's not a full seal around mom's breast. Mom is reporting a tugging sensation, not a pinching sensation. And that mom is not like super sore following feeds. There's no redness or raised areas on the breast tissue. Okay. Letdown is whenever mom's colostrum has transitioned to breast milk and she's producing more milk at that time. Some signs that's occurred is mom is feeling like a tingling sensation in her breasts. Baby's sucking pattern will change to slower, more drawing out sucking pattern, and there's an audible swallowing. I've had a couple times where moms will call into the OB unit and be like, I can't breastfeed my baby anymore. My baby is choking. And that's simply because mom's breast milk has started letting down. So the amount of volume that baby is getting at one time with each suck is a lot of volume of breast milk. So the baby can't keep up with the amount of milk that mom's producing. So what we'll recommend is either hand express forward some of the colostrum that you have, or use like a haka or something to kind of catch that initial letdown so that baby's not being overwhelmed. Okay. Babies should be feeding 8 to 12 times in a 24-hour period. Moms and dads are going to have to wake the baby because babies are not going to wake on their own to feed. moms need and dads need to keep babies engaged with feeds. They should be feeding 15 to 20 minutes per side. The length will decrease as the baby gets older and as the milk is produced, because they're able to get more in a shorter amount of time. How do we know breastfeeding is effective? We need to just keep track of how often the baby is feeding and then their output. Are they peeing? Are they pooping? What is that looking like? Okay. And then we should observe as a nurse, you should be seeing the mom feed at least once in your 12-hour shift, because you need to be able to chart a latch assessment. I know for my hospital, it's our policy that we need to be able to chart latch assessments on every patient each time we have a shift, okay, if they're breastfeeding, because it's important. And it is actually, I think, part of the 10 steps, at least I believe it is, that we need to watch and observe for an appropriate latch. So this here too are some lists of how we know breastfeeding is effective. I'm not going to go over every single one of these items because it's also listed for you in your textbook, which I have the page number for you guys here. Page 592, box 24.3. Okay. So these are some of those breastfeeding positions that I mentioned, as well as what a latch score is. So here you can see cradle position, football hold. Those are the two I probably use the most whenever I'm helping moms with breastfeeding. And then your latch assessment, it goes down through here what those requirements are and what we need to have for a successful latch. So if baby is having difficulty feeding, there are some things that we need to take into consideration. So we should not be supplementing unless the mom desires or there is a medical indication, okay? So you should not be like on night shift if a baby is fussy, taking them up to the nursery and just giving them formula on your own. Like that is definitely not a thing, because we shouldn't be giving babies formula unless it's medically indicated by a provider or the mom has expressed interest in feeding with formula. Why would we supplement a baby? Okay, this is important stuff that you guys would need to know. If a baby is hypoglycemic, right, they are not able to control their blood sugar, we need to be giving them supplementation. If babies are showing signs of dehydration, so like they're not peeing, they're not pooping, they're lethargic, they're sleepy, they're just not really acting correct, we need to be supplementing or getting their feed intake increased. If they're losing weight, we really start to supplement if a baby is losing, at my hospital, it's over 8% of body weight, birth weight. Some hospitals it's 10%. It just depends on what the policy is, but we usually start supplementing if baby's lost usually around 8% of weight. If they haven't had a bowel movement since they've been born, we need to start supplementing. For moms, if they're not having like appropriate milk production, if they're having intolerable cramping with feeds, if they're on certain medications where breastfeeding is not an option, or like we mentioned earlier, if their condition just is not appropriate at the time. Okay. Supplementation methods. So we can use formula, donor milk. We can also just use mom's breast milk if she decides that she wants to pump. That's something we can do. We can use a syringe, a cup, a spoon, a shield, or a dropper to supplement, which in your textbook, there's detailed graphs depicting each one being used. So the other thing too that moms will ask about a lot are pacifier use. Moms should not be using a pacifier. This is our recommendation. Moms ideally should not use a pacifier unless their proper latch is obtained. Okay, so if they're looking for guidelines on that, that is usually what we recommend to them. If baby is having trouble feeding, we definitely shouldn't be introducing a pacifier because it can cause nipple confusion, and then babies were less inclined to nurse. Okay. Some other things that we need to consider is this baby just really sleepy? Is the baby just naturally fussy? Some babies are slow to gain weight. If they're having issues with jaundice, we're going to need to supplement. Preterm infants, we're definitely going to be supplementing or giving them different feeds because they're not going to be able to breastfeed on their own as well as a term baby. And then also multiple infants, right? Because we think breastfeeding one infant is hard. Imagine trying to latch twins at the same time. I've seen it happen. People do it and it's amazing, but it's hard. So here's some stuff. I thought that picture of the pacifier with the mustache was really cute. That up there, this is a nipple shield. We'll put that on moms, especially if they have flat breasts, to kind of like help give baby something to latch onto. So if they have inverted nipples, that's a really good resource for them. This cup feed is the way that we can feed babies colostrum that moms pump out. That's a really popular thing that we will do with like smaller babies or even like preterm infants. So those are just some examples of things that we can do to help if a baby is having difficulty with feeds. So there are some guidelines as far as storing breast milk and expressing breast milk. So like I mentioned earlier, hand expression is a really awesome technique that moms can use to bring forward their milk and their colostrum and have babies like latch more successfully. This can be more effective sometimes than a mechanical pump because moms are able to apply the appropriate amount of pressure and they're not hurting themselves and they're more likely to continue to do it if it's not painful. Some women just physically cannot stand using breast pumps. Like it just is irritating to them and they don't like them. So hand expression is a technique that we can teach moms about. We are responsible for educating moms and showing them how to hand express. This is not something that providers are doing. Pretty much everything having to do with breastfeeding and infant nutrition, like actually performing it, is a nursing duty, is a nursing job. So it's important for us to know how to do all these things. Pumping should begin once the milk comes in or if there's a delay in latching the infant. So if we're not latching baby right away because baby's needing some resuscitation, we need to be starting mom to pump so that she gets that stimulation and ends up initiating lactogenesis. Double pumping, so using a breast pump on each side at one time, saves time and produces milk better. We need to measure the opening of that breast pump so that it is appropriate fit for mom's breast and areola. Otherwise, it can cause moms to become really sore and irritated. And we don't want that because moms are way more likely to stop breastfeeding if it hurts, right? So we want to make sure that it's as comfortable for them as possible. Moms should also know how to appropriately clean their pump parts, how to use their pump before discharge by a lactation consultant or a nurse. Okay. And then breast milk storage, that page there has appropriate ways to store breast milk. Okay. Some other things to take into consideration whenever we're talking about breastfeeding. Returning to work is a big one, okay? Not everybody has a 12 to 16 week maternity leave, right? Some women are going back to work right away. So we need to be mindful about that whenever we're talking about feeds because returning to work and pumping can often lead to a decrease in breastfeeding in general. Like moms sometimes just won't do it um, if they're at work and it's a little bit more inconvenient for them to pump or they're not able to. So we need to help them set realistic goals, give them lots of education on pumping and storing of their breast milk, and encourage portable pumps. I don't know if you guys have seen these, but like they're pumps that literally will just go on and moms can walk around and do their thing. They don't have to sit and like pump, you know? So these are really nice. Like as a nurse, a lot of my coworkers have used these. Well, they'll just throw their pumps on, they'll go into a room and do their assessment of their vitals, and then they'll come and they'll take their pumps off and they'll store their breast milk, which is pretty convenient. And I think it's really awesome to encourage moms to continue to breastfeed. Weaning off of breastfeeding. This is done usually when babies are introduced to other foods if they're being exclusively breastfed. And it should be gradual over a couple of months. If you're just abruptly stopping breastfeeding, that can be a little bit more disruptive and babies may not tolerate that as well. Okay. Milk banking is that pasteurized donor milk we mentioned. Like I said, that's a great option for moms who can't breastfeed or infants who need supplementation. Milk sharing is a relatively, at least I think, a relatively newer idea where a mom can either purchase breast milk from a friend or an external source, or the baby is being breastfed by a different woman that's not the mom. Last week, I had a patient who had a baby via a surrogate, and she was actually from China, and she had a nanny with her who ended up breastfeeding the baby. So, I mean, there's a lot of different ways that babies can get nutrition. We don't need to limit it specifically to just breast milk or just formula. We can get a little creative with it if moms have the means and have the resources available. So some care of the breastfeeding mom, they should be increasing their calorie intake whenever they're breastfeeding because they're going to wear through their calorie stores like really quickly whenever they're nursing babies. Um, Dramatic weight loss is not recommended whenever we're nursing because it says required, but I mean recommended because if they're losing weight really quickly, it can deplete their milk production. Okay. So we want to make sure that moms are getting as much rest as physically possible because, like I mentioned, fatigue, stress, or worry can reduce their milk production. Okay. These are some things that I mentioned here about breast care. We don't want them to use like soap right on their nipples because that can dry out their breasts and make them like really irritated, and also cause like more discomfort and some pain as well. One other thing that we should mention too is breastfeeding is not an appropriate form of contraception. Okay. Some people will say, like, oh, if you're breastfeeding, you're not going to be ovulating, which, as we know, we learned, I forget what week it was, that your ovulation decreases whenever you are breastfeeding, but it doesn't mean that it completely stops. Okay. So if women are saying, like, oh, I'm just going to be breastfeeding, I don't need to like worry about contraception, we need to educate them, like, no, we probably should have something else on board because that is not a foolproof method. Okay. It's okay for women to breastfeed if they become pregnant again, as long as there's no medical contraindications like preterm labor. Why would we be worried about preterm labor if a mom is breastfeeding? While she's pregnant?
She won't be able to adequately feed the baby.
So,
Because of the oxytocin that she's producing.
yes. Who's that? Faith? Was that you? Oh, Haley. Okay. Yeah, that's perfect. Yeah. So whenever moms are producing oxytocin with breastfeeding, what is that doing? That's causing contractions, right? We talked about how that's going to make moms a little bit more painful whenever they're nursing. So if moms are producing oxytocin, that can increase their risk of um, preterm labor because we don't want them to be contracting while they're pregnant, right? So that is something that you guys should know. Let's see. Breastfeeding after breast surgery. This, if mom has like a breast reduction or anything like that, it does not necessarily mean that she can't breastfeed. It just means that it might affect the ability for mom to produce breast milk. They can still attempt it, right? It's fine if moms have nipple piercings and tattoos to breastfeed. They should just wait to get a new tattoo until the infant is weaned. That's not necessarily for like a safety thing. It's just mostly also too how the tattoo can heal if moms are breastfeeding because they still are in that coagulable state, and it can cause tattoos to heal differently. Obesity, there's usually less success with breastfeeding. And then mom should also be checking with doctors if they're using any other type of herbal substances. One thing I want to mention too is if moms are using nipple cream, definitely check with them and make sure that it's not like something that has a bunch of essential oils or fragrances in it, right? There's a lot of companies that are coming out with these nipple creams and like that are being promoted, and then it turns out they have all these essential oils in them that are actually super harmful and irritating to the babies. So we want to make sure we're telling moms like, hey, definitely don't be giving babies nipple cream that has a lot of essential oils in it because it can be harmful to them. So here are some issues that can arise whenever we're breastfeeding. Big one is engorgement. So that is when mom's breasts get big, really big and painful, red. And this is a response of breasts to sudden change in hormones and the onset of larger amount of milk production. So this happens a lot when moms are letting down, when the letdown is happening, when their milk is coming in. They become firm, tender, and hot to the touch. What we need to tell mom, which with all of these, it's important for you guys to know the treatment associated with them. Okay. We need to hand express the milk from breasts and feed them babies more frequently. We need to use ice packs and anti-inflammatory meds. Um, so for engorgement, we still want to encourage mom to be breastfeeding with this. With nipple discomfort, we need to look at baby's latch, make sure it's okay, and encourage them to use nipple creams, the appropriate nipple creams. A clogged milk duct can occur, which is a result of inadequate removal of milk from the breast. So if babies aren't fully emptying mom and some of that milk gets kind of stuck up towards the front of their breast tissue, that can cause the milk ducts to be clogged and painful and irritated. So what we can tell moms to do is use a warm compress to the area to continue to nurse the baby and then wear a supportive bra. Okay. This will increase the likelihood of developing other milk duct related infections, so like mastitis. So if a mom has a history of having some clogged milk ducts, we tell her that they're at an increased risk for developing mastitis or other type of things with like issues with the breast tissue. If moms are not having a good milk supply, this is a big reason why moms will stop feeding. But we need to educate the moms on how we can increase their milk production. So this includes putting babies skin to skin, increasing that skin to skin time, encouraging more frequent feeds with pumping, either hand expression or mechanical, okay? And then check with them to make sure their medications aren't interfering. Some specific SSRIs can decrease milk production because it can be drying. Benadryl is huge in that we do not want to be giving that to breastfeeding moms. Benadryl can dry out milk. Okay. So if you have a postpartum C-section patient and she says that she's super itchy, we should give them Nubane for itchiness rather than Benadryl. Okay. Mastitis is a really big one that you guys have probably heard of, or some, unfortunately, I hope none of you have experienced it yourselves, but it's very common. It's an infection of the breast. Signs and symptoms, these moms are going to present like with having flu-like symptoms. They'll have a fever, they'll have chills, they'll feel really gross, they'll have body aches, headaches, nausea, and vomiting. The mastitis, you can usually see the spot where the infection is happening. Risk factors would be like if the tissue isn't emptying, the milk isn't emptying all the way. If moms are sick on top of breastfeeding, so if they have any underlying like flu or cold or something like that, they are at a higher risk for developing mastitis. We need to tell moms, and they will not want to hear this, that they have to keep breastfeeding on that side. And that has to be probably the most uncomfortable thing in the whole world. They're also going to be on antibiotics, bed rest, and some anti-inflammatory meds. Okay. Moms, if they're sick, they can still nurse. Okay. Because anything in the breast, the milk, it's going to be safe for baby. It's going to be okay. They can still nurse babies. Okay. So here I have a picture of an engorged breast versus a not engorged. And these are some very terrible pictures of mastitis for you, for your reference. Okay. So we'll talk about formula feeding here. We don't have as much information to cover with formula feeding. They should receive iron fortified formula because, as we mentioned, babies with their iron, their stores are depleted within 4 months. So it's important that babies are getting an adequate source of iron intake. And if they're not getting that protein specifically from breast milk, we need to have something that is going to be able to bind that iron so that babies can maintain their iron intake. There is a specific way to prepare formula and a safe way to feed formula. I have that information for you on page 630, so you guys can take a peek at that. It's important too, whenever we're talking about formula feeding, that moms are not overfeeding their babies right away, because like we mentioned, whenever we're talking about, I think it was the GI system last week, babies' stomachs only have so much capacity, especially in that first like 2 to 3 days of life. So feeding a baby an entire ounce is usually not what we want moms to do right away. We want them to have about 15 to 30 mLs in the first 24 to 48 hours per feed. Okay. We don't want moms to overfeed the babies because with formula too, babies can sometimes be more spitty. They sometimes don't tolerate the digestion of the formula as well as if they're being breastfed. So we need to slow the feeds, make sure we're burping them almost every 5 mLs that they're getting, and just making sure moms are aware that formula feeding is a little bit different than breastfeeding. It's because they're directly getting that milk and they don't have to like suck for as long. Okay. Then obviously we're gradually increasing the amount they're getting as they get older. We want to formula feed every 3 to 4 hours, 6 to 8 feedings usually per 24 hours, because we know how much formula they're getting, right? That's what's different about formula versus breast milk. Breast milk, we know how long a baby will nurse for, which gives us a pretty good idea of the quality of their intake, but we don't know the exact ml amount, right? So we don't need to feed them nearly as like often. They should be held for their feedings, and then we need to make sure we're burping them so they're not spitting up and reducing GI upset. So here's some guidelines and stuff for formula feeding and how to prepare formula for you. Okay. Anyone have any questions so far? Cool. So high-risk newborn is going to take up a lot of this time because it's a little bit more content than the formula feeding. So we'll dive right into it. Okay. So it's important for us to know, like, what do we mean by high risk? This is any infant, and it does not matter if they're preterm, it doesn't matter if they're post-term, it doesn't matter if they're at term, who has a higher average or a higher than average chance of morbidity because of conditions associated with birth. So we're going to talk about birth trauma, maternal substance abuse, infection, and congenital abnormalities that can just define our babies as high risk. Okay. These things can be anticipated, and what we mean by anticipated is we've caught them prenatally. Like we know this baby has an underlying congenital abnormality. We're able to kind of prepare ourselves for it. We're able to be prepared at delivery for this. And then unexpected could be something happens at birth or baby requires further resuscitation after delivery. That can be unexpected, that we're going to just have to figure out as the baby is here and as we are resuscitating the baby or taking care of them. So birth injuries, most common are the physical injuries that are sustained by babies during labor and birth. Okay. Some are avoidable. So what that means is like we can use ultrasound. So ultrasound's effective because it can identify infants who may be macrosomic, issues that babies may have or that moms may have less amniotic fluid if babies are in a malpresentation, or other abnormalities that may contraindicate vaginal delivery. So if moms like are going to their scans and their babies are macrosomic, they're type 1 diabetic, their baby is going to be big. Providers can use that information and say, hey, like, we would recommend you do a C-section. You don't have to, but this is a patient that we could potentially recommend an alternative form of delivery because we know and we're anticipating this baby being large, right? So ultrasound can be helpful in that sense. But also we have to take into consideration that babies' weights on ultrasound are not always exactly accurate, right? We usually say they can be a pound off, less or more. So those are some things to take into consideration. Elective cesarean sections could happen because of that. They could happen because we know that baby is going to be born with a specific congenital abnormality and we can give mom the option of delivering via C-section. So those are good resources that we have in our back pocket to be able to kind of minimize the babies that are being born with these injuries. So a lot of these injuries are going to resolve without any type of treatment. Some significant birth injuries are unavoidable. And what I mean is like, if there's a difficult or prolonged labor, right? So we're looking at like babies being delivered with a vacuum or a forceps, that can put the babies at a higher risk for having like either the clavicle fracture or head injuries or like more brain or skull injuries, like we're looking at those kind of things if we have a difficult labor. If baby has an abnormal presentation, there can be some injuries associated with that. And then during childbirth, right, if there's a shoulder dystocia, we're worried about babies having clavicle fractures. And those are kind of things that we're not going to be able to avoid because they just happen during labor. So talking first about skeletal injuries, this usually results from forces that alter normal position and the relationship of arms, shoulders, and neck. A big one is forceps delivery, kiwi vacuum delivery, shoulder dystocia. Those are big ones that can lead to skeletal injuries, okay? Linear fractures or depressed fractures. So if an artery is lying in a groove on the undersurface of the skull is torn as a result of a fracture, babies can have increased intracranial pressure. Okay. Unless a blood vessel is involved, usually linear fractures are going to heal without lacerations of either the skin or the dural membrane. These depressed fractures or the ping pong ball indentations can occur during difficult births from pressure of the head on the bony pelvis, which I thought I had a picture to show you guys. It might be on a later slide here. But so basically where that fracture or that injury is going to determine how bad or how significant the injury is going to be for the baby, okay? So linear fractures, like I said, unless the blood vessel is involved, they're going to heal without special treatment. And these then depressed fractures is whenever the soft skull becomes indented with those ping pong ball indentations, and there's pressure of the head on the bony pelvis. We've talked a lot about clavicle fractures, so I would star those. That's going to be important. Clavicle fractures are things that we see a lot in labor and delivery, so it's important for us to be able to identify them. This is the most fractured bone during birth. Shoulder dystocia is the biggest cause of clavicle fracture. Signs and symptoms include like limited arm motion. They're going to be crepitus over the bone. So whenever you're palpating the baby's clavicles, you're going to feel that crepitus. Once you feel one, you're never going to forget it. Like it's very distinct. You're definitely going to be able to tell when a baby's clavicle is fractured. Also because like they're not going to have reflexes on that side with that arm. That side is going to be injured. They're not going to be able to move it the same way they would be on their unaffected side. Treatment, we're obviously going to be handling these babies with great care. The other thing is like we want to contain that hand against the chest. Okay, so we want to make sure that baby's hand is stabilized, that arm is stabilized so that it gives the baby chances to heal. Infants and children heal extremely rapidly. So most of the time, we do not need to do anything like surgically with these kinds of fractures. Usually the provider will just like kind of, like I said, brace that arm and then let the baby's body take care of the rest. Okay. Peripheral nervous system injuries. Plexus injury results from forces that alter the normal position and relationship of the arm, shoulder, and neck. So the biggest ones I want to talk about are the brachial plexus injury. So like Erb's palsy. This occurs whenever there's damage to that upper plexus nerve. And it results from stretching or pulling of the shoulder away from the head. So like in a really traumatic birth, like a shoulder dystocia, when the provider is like pulling on that baby's head to try and get the baby's shoulder to dislodge from under the pelvis, we run the risk of pulling that nerve right up here along their neck. Okay, so that's really dangerous for babies. It can have paralysis effect on the extremity and muscles, and that arm, that affected arm, is going to hang limp at the baby's side. Okay. Their finger and wrist movement will usually remain normal with Erb's palsy. What we want to do as nurses is prevent contractures, okay? So we want to make sure there's correct placement of that humeral head, that the arm is abducted with external shoulder rotation. We're going to do some passive range of motion exercises with these kiddos to make sure that like we're making sure that the baby's not contracting and staying in that position. Parents are taught with this infant to hold their baby in the football position. Unfortunately, this recovery is a little bit longer, but it's still with babies, they heal very quickly, 3 to 6 months. Okay. So, one thing that you guys should know too for exam 3 is the difference between like your Erb's palsy, your Klumpke palsy, your facial palsy, and then just your normal phrenic nerve injuries. Because know the signs and symptoms and what we're doing for these babies. Okay. So Klumpke palsy is damage to the lower plexus. So we have that little picture up here showing the difference what the hand looks like with Klumpke's palsy versus Erb's palsy. So you can see that their wrist drops and the fingers kind of like relax almost, whereas the Erb's palsy, the hands are kind of curled in. So clunky palsy is a lot less common than Erb's palsy. And what occurs is the muscles of the hand are paralyzed. Okay. Facial palsy is going to affect our cranial nerves, our facial cranial nerve. And this is loss of movement of the affective eye. So there's like going to be drooping in the corner of one of the mouths. Basically, the one side of the face is going to be affected. It's going to be really noticeable whenever your baby cries. It usually resolves in a couple hours to days. It doesn't last very long. But with these babies, we need to help moms with feeding because their latch is going to be discoordinated. Okay. And then last but not least, our phrenic nerve injury. This is what happens. Let me see. These injuries are usually unilateral and result in diaphragmatic paralysis. And you can see these injuries usually on ultrasound, which show paradoxical chest movement and an elevated diaphragm on the affected side. So sometimes this injury is associated with brachial palsy. This one is really important to know that respiratory distress is the most common sign of this injury. Okay. Because injury to the phrenic nerve is usually unilateral, the lung on the affected side is not going to expand as well. And respiratory effort is going to be ineffective, and babies are going to have to work a lot harder to breathe. Infant is positioned usually on the affected side to facilitate expansion of the uninvolved lung, right? Because we want to try and promote that baby's respiratory effort to increase. So we're going to position them in a way that's going to help with that lung expansion. Anyone have questions over those things? You guys still with me? I know it's a lot of info. You're doing great. Okay. So moving on here, we have neurological injuries. So this is a lot more prevalent in very low weight or low birth weight babies. They're prone to intracranial hemorrhage because they have more fragile capillaries in their body system. So these babies too are going to be vulnerable to ischemic injury because of variable cerebral blood flow. So like cerebral palsy, seizures, or hydrocephalus. So these neurological injuries are usually diagnosed in the first 2 years. There are less severe deficits diagnosed like in the school age. So what I mean by that is like your ADHD, your learning disorders, those kind of neurological things can happen or be seen later on in school age, which as we know is not like very severe things, but still things that are going to potentially affect quality of life in the school age child. There's a big table on page 641 that show a lot of different neurological complications that you guys should review. Some other things that can happen with neurological injuries would be like therapeutic hypothermia if the babies are over 35 weeks. Because babies are going to be trying to compensate for the damage that's happened. So they're going to be reducing the severity of by causing this hypoxic ischemic encephalopathy. So this is common in like term and late preterm infants, and it usually happens after the first 6 hours of birth. Another thing we must talk about is neonatal infection. The biggest one is sepsis, okay? And neonatal sepsis is honestly terrifying. And whenever these babies start to present with sepsis or any other type of infection, it progresses extremely rapidly, Okay, that's something too to know. Like when these babies get sick, they get sick really, really fast. I had a baby that went septic and like at like 7 o'clock when I came on shift, the respiration rate and everything was normal, temperature was normal, and then by 9 p.m. the baby's respiratory rate was like 140s and the temperature spiked up to like 100. So these babies will turn on you really, really quickly. So it's important that that's why it's important we're assessing our infants regularly so that we can identify the moment when it becomes scary. So sepsis usually occurs within the first 28 days of life. It's usually it can be systemic bacterial, viral, or fungal. Babies are very high risk for contracting sepsis or contracting infection because, as we know, their immune systems are a little bit more depleted when they're newborns, right? So that's why we're telling, like, at Thanksgiving, like, the aunt whoever, please don't kiss my baby right on the mouth. Like, we don't need that. We don't need those germs. Everyone should be washing their hands when they hold the babies, not coughing on babies. Usually moms, I know in the first like couple weeks are usually staying pretty close to home because they don't want these babies out and about. Risk factors for sepsis. A huge one is pneumonia. If your baby has developed pneumonia or they're having respiratory problems at delivery, they're at an increased risk for developing sepsis or a different type of infection. Okay. Also, babies that have contracted or been exposed to HIV or other STDs are going to be at an increased risk. So we divide sepsis when we're talking about neonatal sepsis into early onset and then late onset. Early onset happens within 72 hours of birth, and this is the one that progresses way more rapidly. Our preterm infants are at high risk for this. If moms had a prolonged rupture of membranes, if mom had developed choreo during labor, or if moms have a fever. These are all things that can put babies at a higher risk for developing sepsis, okay? And then we also have late onset, which is 7 to 30 days of age. And this is community acquired. So they're getting this from a family member or they're getting this from being exposed just in the environment. So that's why we're telling moms, like, encourage other people to wash their hands. And if they're sick, not to be around your baby. Signs and symptoms of neonatal sepsis. I would highlight, star, circle, whatever you want to do, this section, okay? This can be confused with hypoglycemia and respiratory distress because they present very similarly. Babies are going to have a temperature. They're going to be pale. They're going to be breathing really fast and they're going to be working really hard to breathe. They're going to be super lethargic. They will not be waking up for breastfeeding. They will be pretty much not comatose, but they're not going to be as active or engaged as they usually would be. Okay. They're going to not feed super well. They won't be gaining weight and they're going to be overly irritable. Okay. What are some labs that we're going to grab on these babies? A big one is a CBC. What do we care about in their CBC?
Is it the white blood cells?
Yep, we're wanting to know how high these babies' white blood cell count is. Okay. We also too will analyze like liver function. We're going to get blood cultures because while there are 2 antibiotics that we typically prescribe babies, do you guys know what those are? This is bonus.
Ask that question one more time.
What are the 2 antibiotics that we typically use for treating infants? The most common.
Amoxicillin.
So one of them is gentamicin.
Ampicillin.
And ampicillin. Yep. Yep. Gent and amp are the 2 that we give babies. But we're still going to want to get blood cultures because we want to know exactly what's growing and what's happening to the baby. We're also going to get stool cultures, urine culture, and sometimes even a sampling of the cerebral spinal fluid. depending on how sick these babies are. If baby's white blood cell count starts to dramatically decrease, this can be an ominous sign, especially if babies are really early on into the infection or the disease process. Okay. So our treatment for neonatal sepsis, they're going to be getting antibiotics, sometimes antivirals, sometimes both. And usually we start that treatment before, after cultures. But in my experience, whenever we've been transferring babies or taking care of babies that are presenting with some type of infection, we usually will start them on AMP and GEN and then grab cultures. And then if we need to make a change to their treatment regimen, we do so following the cultures. Okay. Antibiotics and low birth weights without positive cultures, it can sometimes be associated with necrotizing enterocolitis, which is why they tell you to wait until the cultures they've gotten cultures before starting on certain antibiotics, especially in those low birth weight or preterm infants. So then we also want to be assessing for signs and symptoms of septicemia, which I have listed there for you. We do want to encourage moms to still breastfeed because this can increase baby's immunity, right? It's helping with their build up their immune system. Routine suctioning is not recommended anymore because it can compromise infant immune system and can cause hypoxia or increase baby's intracranial pressure. So like NRP, neonatal resuscitation, we are not supposed to be deep suctioning those babies with like a long suction catheter because it can cause more damage than it will benefit. Okay. Typically, if babies have a lot of excretions, it's because they have a lot of air in their bellies and then they're making more secretions because they're not able to fully like hold down everything. So these babies like typically end up getting intubated and have an OG. Okay. You don't really need to know that. That's just kind of an aside. But we just don't want to be suctioning these babies because it can increase their intracranial pressure and cause some hypoxia and can damage and be more damaging than beneficial. So moving on to congenital infections. So like infections that mom have during pregnancy that can affect the baby once baby has been born. So torch is a good mnemonic. You guys have probably seen this before. So toxoplasmosis. Your other category is like your HIV, syphilis, hepatitis B, West Nile virus, rubella, cytomegalovirus, and then herpes simplex. Okay, which I think we talked about in our labor and delivery section, but we don't let moms that have an active lesion from herpes deliver vaginally because that can cause the disease to pass to babies. And herpes is very detrimental in an infant. For like humans, like I think now it's like 1 in 4 people have genital herpes or something in the United States. It's become a lot more common. But for infants, it can have a lot more of like a long-lasting, long-term effect on them and can affect like neurological development. Like it can get pretty intense. So that's why we screen moms and make sure we're checking moms before they even deliver to make sure that the babies aren't going to be at risk for developing anything. So drug exposed infants, we'll go through each one of these briefly. Moms who smoke during pregnancy, the biggest risk that we see is a low birth weight infant. Sometimes moms that smoke during pregnancy will also run the risk of preterm labor. We talked about those kind of things during labor and delivery portion of the class, so I'm not going to go over it super in depth. The biggest one I want to talk about is fetal alcohol syndrome. This is the most severe form of disability from alcohol consumption in pregnancy. So this is a very specific looking infant, and individuals that are born with fetal alcohol syndrome have abnormal facial features. I have a picture on the next slide of what an infant or a kiddo would look like with fetal alcohol syndrome, but they're going to have small eyes. They're going to have short palpebral fissures, thin upper lip, flat mid surface of the face, and they just have some distinct characteristics. Babies also can go through withdrawal if mom's drank during pregnancy, and withdrawal symptoms are going to look like that jitteriness, the increased tone and reflex response, They're going to have irritability. They may have some seizures. These babies also might have growth defects, deficits, and then some learning disabilities that are discovered later on in life. Okay. With marijuana use, there's not a sufficient amount of research available yet on this and the effect. The stuff that what your textbook says is that it potentially can cause fetal growth restriction or preterm delivery. Okay. Opioids, so like your morphine, fentanyl, heroin, will also cause withdrawal symptoms in the fetus. We're going to talk here about neonatal abstinence syndrome, and that's something that you definitely will want to study when preparing for the exam. But an important thing too to mention is that withdrawal symptoms in a baby, they are related to the length of use and then also the gestation of infant. So if a baby is born prematurely who's exposed to opioids or other type of detrimental things in their pregnancy, they are going to have a lot longer or more severe withdrawal symptoms than a term infant of a mom who maybe took opioids once during the pregnancy, right? With cocaine use, there's reduced fetal growth, specifically the neonatal head. And then there's going to be long-term effects on like language, problem-solving skills, attention span, behavior, memory. And then your methamphetamine is like similar with your cocaine use. So here I have pictures of an infant and a child with fetal alcohol syndrome. So you guys can have that as a reference. It's like what they can present with clinically. Okay. So some other things that we have to take into consideration that babies can withdraw from, SSRIs, okay? Specific types of anti-anxiety and antidepressant medications can display signs of withdrawal in a baby, okay? So our signs of withdrawal would be like they're super hypertonic, they tremor a lot, they are very wakeful, they have that high-pitched cry, and they're going to have difficulty feeding. Okay, so I know like Zoloft, I think, is one of the only SSRIs that is safer in pregnancy use. Other than that, like providers are usually pretty cautious with prescribing SSRIs if moms haven't been on them before. If they're used to a specific medication, providers will usually just give them like the signs and like the warning signs and symptoms for babies and just encourage them to like use them cautiously. But that doesn't necessarily mean they will tell moms to stop. This also can increase the baby's risk for pulmonary hypertension, and because it can be transferred from mom in their breast milk. The other one too would be like your benzos and your barbiturates. It's more severe with your benzodiazepines than it is with your barbiturates, the withdrawal. Okay, so this brings us to neonatal abstinence syndrome, which, like I mentioned, this is something you guys are going to really want to know for your exam. Okay, this is a set of behaviors exhibited by infants exposed to substances in utero, okay, whenever they're delivered. 55 to 94% are experiencing withdrawal. Early identification of this is essential. Early identification of any baby that's going through withdrawal is essential because we need to start them on treatment and monitor them very closely right away. They're going to have some neurological symptoms. So that high-pitched cry, they're irritable, they can have seizures, all those things that we've mentioned already. They also will have some GI stuff going on. Their sucking is not going to be very coordinated. It's going to be super frantic. They're not going to be able to latch appropriately because their sucking reflex is all out of whack. They also might have just poor feeds, and they might have some vomiting associated with feeding as well. Okay. From a metabolic standpoint, these babies will also have like frequent yawning, which might sound random, but it's just a compensatory mechanism. Their respiratory rate could be high. They might start like sweating or having like perspiration more. They will not be able to keep their temperature stable. So these babies run the risk of hypothermia because they're not going to be able to regulate their temperature on their own, and that temperature is going to fluctuate pretty drastically. So what can we do for these infants? We can swaddle them. We need to decrease the environmental stimuli. So like make sure the lights are dim in their room, that there's not a bunch of people in there, that we're minimizing the noise. And then keep them skin to skin with mom if it's appropriate, as long as babies aren't like declining super quickly. So one thing that we do in the nursing on the floor is we'll do this neonatal abstinence scoring system for patients that we identify as going through withdrawal or are at a high risk for going through withdrawal. Usually it's done once every 12 hours. And this just kind of shows how their feeds are going, if they're having any of those neurological signs and symptoms. And then this is a good tool that we can use if we're going to be giving report to a pediatric provider so that they know like how this patient is displaying, right? So some hemolytic disorders that we're going to go over, which I feel like we've talked about in like 3 different weeks, but it's a really important thing. So we need to make sure that we understand this concept, is our blood incompatibility. So in the RH system, the person, so we're talking here about isoimmunization, which is what happens when the maternal antibodies attack and destroy the fetal erythrocytes, right? So with these moms, we're going to be giving them that RhoGAM for the Rh immunoglobulin to prevent the moms from producing antibodies against the baby. Okay. We're worried here about so let's go back to first to talk about exactly what isoimmunization is. So this can develop when the mom is Rh negative and the baby is Rh positive, right? Although mom and baby circulations are separate, there is evidence where fetal red blood cells can enter mom's circulation. So then moms are going to naturally make defense mechanisms to respond to these cells by producing those antibodies to attack those fetal cells. Okay. Under normal circumstances, isoimmunization doesn't usually have effect during the first pregnancy with an Rh positive fetus because that initial sensitization to Rh antigens usually happens after labor when there's mixing of maternal and fetal blood. Okay, so we're not as worried about it with the first pregnancy, but if moms are having reoccurring miscarriages or infertility or whatever, we need to make sure we know her blood type because it could be a manner as small as just giving her a RhoGAM injection. Okay. But then we worry, obviously, after the blood has mixed and stuff out in a subsequent pregnancy with an Rh positive fetus, because that mom is going to make antibodies to attack and destroy fetal cells. So then that's why before moms even leave the hospital, we're administering RhoGAM to Rh negative or O blood type moms. Okay. Another hemolytic disorder that we need to talk about is the erythroblastosis fetalis. This condition begins in utero. The fetus attempts to compensate for progressive hemolysis by accelerating the rate of erythropoiesis. So what this basically means is that babies are going to be producing immature red blood cells. Okay. In severe cases, this can cause fetal hypoxia, right? Because these red blood cells are not fully mature, so they're not going to be delivering the oxygen content that is necessary for baby to be able to be regulating their O2 levels. What we see mostly from a clinical standpoint on our side of things is these babies will present usually with hyperbilirubinemia or like their jaundice faster. Right? And then obviously we have our ABO incompatibility. So that's when babies have mom with O and babies with A or B blood type. And this again places the fetus at risk of mom's body producing antibodies to fight fetal cells. And this is a little bit different than that blood isoimmunization that we talked about because it can occur in the first pregnancy. And what we can see with these babies too, again, is this jaundice and anemia is what we're worried about. So we're talking here about infants of the diabetic mom. It's really important to know if moms are pre-diabetic, if they're gestationally diabetic, and if they're pre-diabetic, if they're type 1 or type 2. Are they insulin dependent? Because that's all going to affect fetal growth and development. These babies are going to be big. That is the biggest thing with babies born to diabetic moms is they're going to be macrosomic. Okay. So we talked about too with those skeletal and tissue injuries that a macrosomic baby is at a higher risk for these injuries because their birth is usually more traumatic and it's usually longer and it's usually a harder delivery because they're bigger babies, right? So we need to be aware of that whenever we're taking care of diabetic moms. Like if I have a mom that's diabetic in pregnancy and we know that we're anticipating a big baby, I'm making sure I have another set of hands in the delivery room. And I'm also making sure that I have a stool present at the bedside if we see any signs of shoulder dystocia. Because a macrosomic baby, what we're worried about is a shoulder dystocia. I would write that down, guys, because we're worried about that a lot with macrosomic babies, is that shoulder dystocia. From a diabetic mom, we're worried about hypoglycemia in these babies, so we need to breastfeed them more frequently. They're also at a higher risk for respiratory distress syndrome. And that's because this excess glucose in utero causes increased insulin production, and then that can decrease the surfactant, which we talked about last week. That surfactant that's important for making sure that alveoli in the lungs can properly expand and that the lungs can smoothly inflate and deflate for respiratory effort. This excess glucose can decrease that surfactant production, so it can lead to respiratory distress in these babies. Okay. These babies also are at an increased risk for developing congenital abnormalities. So for these babies, we're going to be assessing for anomalies. Obviously, if they're showing any signs or symptoms of respiratory distress, that's something that we need to take care of immediately. We're monitoring them for those birth injuries, keeping an eye on their glucose. We want their glucose to be over 40. And we're managing hypoglycemia if they're showing signs or symptoms or if their blood sugar is unstable. So that is getting baby to breast, feeding baby, administering oral glucose gel if that's appropriate at that time. And basically just like making sure that we're keeping a good eye on that as well as their temperature regulation. Because as we know, if babies are hypoglycemic, they're at an increased risk for hypothermia because their body is going to be compensating for the low amounts of glucose and burning through their fat stores, right? So we want to make sure we're helping them with their temperature regulation as well. Okay, I'm gonna run to the bathroom, so give me 5 minutes, okay? I'll be right back. Thanks, everybody. Okay, we are almost done with this PowerPoint here. So you guys are doing awesome. Does anyone have questions so far? All right, well, we are almost there, so let's just go ahead and finish up here. All right, so some congenital abnormalities that we're going to talk about. Big one is Down syndrome. The other ones too that we talk about a lot are spina bifida and anencephaly. The most common congenital abnormalities that can cause more severe problems would be like your heart disease, abdominal wall defects, an imperforate anus, neural tube defects. Some cleft lip or palate injuries can be pretty detrimental, especially whenever we're talking about nutrition and feeding babies, right? That's a big one. And then development of hip dysplasia or like club feet. Okay. We're going to talk about the different cares and treatments and what was recommended with each and every one of these different ones. So first up is Down syndrome. This is the most common chromosomal abnormality. We talked about this a lot when we were talking about genetics, genetic testing. We know that alpha fetoprotein is what we can test for in pregnancy to detect or show if moms are going to have like high risk or low risk, depending on the alpha fetoprotein and their genetic screening. This can also be diagnosed with an amniocentesis. So if their AFP comes back and it's indicative that there could potentially be a risk for Down syndrome, moms can opt to have an amniocentesis to tell them whether or not this will definitely happen or the baby will be born with Down syndrome. That can see mild to severe mental retardation, some physical abnormalities. I have here how a baby is going to assess on the floor. If you guys want to just read through that too. The biggest thing with Down syndrome kiddos is they're hypotonic. So when normal babies, when they lay, their arms are usually up here like this. Down syndrome kids, their hands are going to be like more down at their sides. Their reflexes aren't going to be as quick. It's going to be kind of delayed. And their tone overall is going to be hypo. It's going to be lower. It's not going to be as reflective. Okay. The other big one too that we see is like a protruding tongue and those close set eyes. What we worry about with Down syndrome babies are those congenital heart deformities. Down syndrome kids a lot of times have heart development issues. Okay, so if we know that a baby is going to be born with Down syndrome, it's not uncommon in prenatal care for a patient's provider to order them a fetal echo or other like tests to see how baby's heart is developing, or if we're like looking at the baby having any other type of like heart issue going on. Okay. These babies are going to have a poor resistance to infection. They're going to be prone to respiratory and ear infections and some speech and hearing problems as well. Okay. Spina bifida babies. The biggest thing with these babies that we care about a lot, which you guys should know this for sure, is we want to prevent infection or injury, right? I mean, kind of make common sense-ish. That baby has an open wound when they're born. So we want to make sure that that is being cared for appropriately so that these babies don't develop any infections like sepsis or anything like that, right? So how do we do that? After delivery, we're placing a moist sterile dressing of saline or an antibiotic solution over to prevent like drying of the sac and prevent like infection and keep that wound clean. We are going to position these babies differently so that we're not putting pressure on that sac. And then obviously extensive skincare is really important. And we also want to make sure these babies are still getting that bonding time with mom and dad. Because just because they're in the NICU doesn't mean that we can't put babies skin to skin. It doesn't mean that we can't offer moms to hold the babies. We just need to kind of give them a little bit more direction as to how to safely handle these babies because they are at an increased risk for infection or other abnormalities as well. So a couple other big ones would be your hip dysplasia, which we briefly talked about or was in the PowerPoint for last week on week 7. This applies, like there's different degrees of hip dysplasia. It's when like the head of the femur is partially or completely displaced, so their hips dislocated. It's way more common in girls. It's probably has an anatomy component to it, but I'm not entirely sure why. It's more apparent whenever a baby or toddler begin walking. Usually their folds, like their gluteal folds, are not going to be symmetrical, and their one buttock is going to appear like higher than the other one. So you should be able to tell on assessment um, whether or not these babies have this hip dysplasia. Um, Treatment, the hips are going to be maintained in flexion and abduction for about 4 to 8 weeks. Some surgical intervention may be necessary depending on the degree of the dysplasia and how severe it is. And then the other one I want to talk about here would be like your club foot. Club foot is the most common deformity. I have a picture there of that where the foot is like turned in. It can also occur whenever the baby's foot is turned outward. This happens, like you can tell sometimes with this whenever a baby or a child is going to walk on their toes and the outer borders of their feet. So they're walking in a different kind of manner. And that is part of the assessment that we would see whenever we are assessing these babies for the club feet. Treatment, we usually are putting these babies in a cast or splinting the foot so to keep it from like rotating in or out. And then we're also educating our parents on assessing skin breakdown, how to perform appropriate cast care for these babies, how to keep it hygienic, what we do for like showering, bathing, whether or not the cast can get wet. That's important stuff that we need to go over with parents. And then also like as nurses, it's our job. Like we need to be providing a good and more emotional support to the parents because I mean, nobody wants their kids to be hurting and it's going to be really hard for them to be going through something like that. So just having that in the back of your mind whenever you're providing care for these patients, that we need to also be caring for parents at the same time too and giving them good resources. Unfortunately, with clubfoot babies, they might need surgical intervention depending on how severe the deformity is and how it is impacting their everyday life as well. Danielle, are you still with us? Do you mind coming back on? And if you're driving, you can just log out and then log back in.
Oh, I'm here. I'm sorry. I just was having trouble with my mute.
Sorry, not you, Professor McBride. I meant Danielle McMillan.
Oh, I apologize. I heard my name. I was like, oh, that's me.
No, you're fine.
I am also here.
Okay,
I also could turn my camera back on. My Zoom was being really weird and my camera was cutting off, but I switched to my phone, so I'll turn my camera on too. So I'm setting a good example.
Okay, thank you. Okay, so cleft lip and palate are somewhat common that we see sometimes in babies. So you can see a picture here, that is the cleft of the lip. There's the cleft of the lip up there. The palate can be internal that you might not necessarily see, but if they have a cleft of any type, we need to be able to monitor that because it can very much increase their nutritional intake, right? So babies with cleft palates and lips have an increased risk of ear infections. These they need to be repaired surgically. Usually this happens before babies are 3 months of age. And we also will feed these babies using a specific type of bottle. So we give babies specific bottles for cleft lip and palates so that the milk can still go down correctly. They just need to be formatted a little bit differently for the babies because obviously their anatomy is a little bit different. Whenever we talk about cleft and lip palates too, we also need to tell and educate moms on making sure we're monitoring the output of the babies because that's going to make sure that we know if their nutritional intake is sufficient or not, right? So nutrition and making sure these babies are getting adequate nutrition is like very, very important. So I think the last things here we're going to really talk about are the preterm infant. So these are babies that are born before 37 weeks of gestation. This is its own type of disease process because we have see a lot of immaturity of the organ systems, right? So these babies are going to be obviously at a higher risk for infection. These babies are going to be at a high risk for respiratory distress syndrome. They're at a high risk for obviously sepsis, which falls under the category of infection. But these babies, because they're at the immaturity of all of their systems, are going to be at an increased risk for a lot of the conditions that we've already talked about and mentioned. So a big way that we reduce infections in preterm babies is they need to be treated for GBS. Moms need to be treated for GBS in labor if their GBS status is unknown. Do you guys know about what gestational age we test moms for GBS? We mentioned it a couple weeks ago.
37 weeks.
It's usually 35, close. But 35 weeks and up is usually when we're testing for GBS, okay? Which is that swab where we take it from the vagina down to the rectum. Let's see here. These babies are also at a high risk for hypoglycemia and jaundice, hyperbilirubinemia, because of that immature organ system. These babies are going to be super small. Their head is still going to be larger for their body. They're going to have the more translucent skin, and they're going to have more of those fine hairs on their body because they're born prematurely. They're immaturely developed. They're going to have greater respiratory pauses and then have periods of like really, really fast breathing. This can be considered normal for them. It's not something that's super concerning or a sign of respiratory distress. But we usually will have these babies on ventilation or assisted respiration if they're very preterm. We want to watch for shock, and then depending on how immature these babies are, so depending on how preterm they are, the greater risk they have for potential disability or other type of neurological development issues, growth issues, all the other things that we've been talking about as well. Okay. Our late preterm infant, which is really important that you guys know what is defined as preterm, late preterm, term. So I would know what weeks fall and what you should know those. So a late preterm infant is born between 34 and 36 and 6 days weeks of gestation. They have also a higher risk of issues because they're not going to be able to properly thermoregulate, and they also will have a immature metabolism, so they will not be able to regulate their blood sugar as effectively. They're also at a high risk for sepsis and respiratory distress syndrome. Okay, just think whenever you're thinking of preterm babies, these babies are born too soon. So not all of their body systems have fully finished developing. So they're going to be at an increased risk for all of the different abnormalities that we've talked about throughout the class. So the biggest complication of preterm birth is your respiratory distress syndrome. This is going to be responsible for more infant deaths than any other disease, and it's usually seen mostly in preterm infants. Term infants with respiratory distress syndrome is usually a result of a traumatic birth or difficulties during labor. But preterm deliveries, almost every preterm infant that I've helped deliver, we've had to intubate because of respiratory symptoms or other things that are going on. Surfactant deficiency is a big thing too with these babies because their surfactant is not going to be fully developed. They will not have produced as much surfactant, so their lungs are not able to expand as successfully as a term infant would be. Surfactant is usually administered in the NICU via a ET tube. So whenever our babies are intubated, we can administer a baby surfactant to help with that lung expansion and that alveoli function. Okay. These babies will need oxygen therapy. Usually it's by tube or intubation. And then we're giving them continuous positive airway pressure. CPAP is the way that we're delivering their oxygen to them. That's going to help maintain that lung inflation and help with their work of breathing. Okay. Some manifestations of preterm birth I have listed there for you that you guys can review. Most of them are signs and symptoms of respiratory distress. Some associated complications with preterm deliveries could be a pneumothorax, which we got that picture up here, bronchopulmonary dysplasia, which is that lung disease that can occur because of mechanical ventilation and long-term O2 use. Meconium aspiration syndrome can occur because usually, like sometimes if moms are in labor for preterm babies, they're going to have bowel movements in utero because they're under stress in labor and they have a risk of swallowing that meconium, which causes their work of breathing to increase and makes it even harder, right? Pneumonia can also lead to any of these, which we need to monitor baby's temperature. They can also have an increased respiratory rate. And then also apnea of prematurity. So sometimes we can administer caffeine or a neurostimulant to these babies to help with work of breathing, to help increase their respiratory rate if they are experiencing apnea. We also need to monitor their urinary output and their heart rate because their heart rate can increase if we're administering caffeine, right? Because it's a stimulant. So we need to monitor the babies for that, as well as any irritability that may arise. And then, like we kind of mentioned before, associated symptoms with premature babies would be your sepsis, which you definitely need to know your signs and symptoms of that. The other thing is your cold stress, which we had talked about last week when babies will go through their brown fat stores because they're burning through to try and regulate their temperature, which can also lead to hypoglycemia. So we need to know the signs and symptoms of cold stress. Okay, definitely know those. And then your hypoglycemia is a big one. Definitely know your signs and symptoms of that. Your weak cry, tremors, sometimes some convulsions, lethargy. And then like a glucose less than 40 would be what we would consider hypoglycemic. Okay, so definitely know your numbers whenever you're going into your exam. A baby's blood sugar over 40 is acceptable. Under 40 is hypoglycemic, and we would need to do some interventions. Okay, so what would our interventions be for hypoglycemia? I know we're almost done, so I'm sorry to ask you a question, but what would we want to do if our baby's blood sugar is low?
Check the temperature.
Yeah, we would want to check their temperature because that can affect thermoregulation. How would we help their blood sugar? How would we help a low blood sugar for a baby?
I said glucose check.
Yep, we would check their glucose again. What would our nursing intervention be? What would you do, like, to bring it up?
Can we warm them?
Yep, you can make sure they're warm.
Give them something, a formula or food?
Yep, exactly. Yep.
Okay.
It's not a trick question, I promise, guys. Yeah, if the baby's blood sugar's low, we're gonna be feeding them. We'll put them skin to skin. We'll either give them formula, we'll latch them to breast if it's appropriate, or we'll administer some oral glucose gel. But we want to get that blood sugar up. All right. Another thing that can occur with these preterm deliveries would be retinopathy of prematurity. So there's some abnormal blood vessels in the retina, and that's usually a result of a high arterial blood O2 level. And that's usually a result of babies having continual oxygen therapy whenever they're premature. Okay. And then that necrotizing enterocolitis that we talked about with that antibiotic usage. So our overall care of our high-risk baby, we want to make sure that we're supporting their respiratory system. That could include an ET tube and ventilation, or it could be an oxygen but be a face mask, depending on how premature this baby is and what they're presenting as. Making sure their temperature remains stable. We're shielding them from infection, ensuring adequate hydration. These babies are not going to be having intake via breastfeeding if they're super premature, right? They're usually going to have a tube that we're going to be doing feeds with. So making sure we're doing that as we need to and as ordered by our physician, helping them conserve energy, which can be not latching them and not breastfeeding, because whenever they try to breastfeed, that's going to burn through their energy source too. providing skincare, considering their developmental status and how their development is going to be after discharge. And then also like facilitating bonding with moms and parents, guardians. We want to make sure these patients are still being able to bond with their caregivers and their loved ones. Okay, so just because they're in the NICU doesn't mean that we're not going to be letting them skin to skin. We still want to try and increase that bonding and promote that as well. Okay. Okay, you guys did awesome. I know that's a lot of information. Okay. Let's see what time we got. Yeah, so you guys, since we didn't take a break, we'll go ahead and you guys are going to be good to go. Lorena, if you'll stay after. And then I think I had one other student that was going to stay. Yvonne, are you staying after?
No, sorry to also interrupt in between that, but McBride helped me.
Okay, cool. But you got it all situated? Okay.
Can I stay after Miss Young? I have a question.
Yeah, if anybody has a question or anything they want to talk to me about, feel free to stay after. But if not, I hope you guys have a really great Thanksgiving. Everybody stay safe and have fun with your families, okay? And if you need anything in the meantime, just reach out.
You too. Thank you.
Thank you.
Thank you.
Thank you so much. Have a happy Thanksgiving.
Thanks.